Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Common Variable Immunodeficiency, or CVID. So what is CVID? This is an acquired antibody deficiency and includes a heterogeneous group of diseases that have B cells present, but with failure to produce IgG, IgA, and in some cases IgM. Some types may be associated with sarcoid-like granulomas. Autoimmunity involving other organs is also common. CVID affects approximately 1 in 30,000 people and may be inherited or sporadic. If inherited, this is usually due to an autosomal dominant inheritance pattern and has a variable phenotype. Most cases, approximately 95%, present in adulthood. The clinical presentation of CVID comprises multiple aspects. Firstly, they may be related to antibody deficiency, and this would include recurrent bacterial infections, particularly affecting the respiratory, the GI tract, and skin. Secondly, autoimmunity, which is organ-specific, may be seen. This includes, for example, autoimmune thyroid conditions, hematological problems such as anemia and thrombocytopenias, as well as arthritis, usually either reactive or septic arthritis. Finally, granulomas may be seen, particularly in the lungs or leading to hepatosplenomegaly. When assessing for someone with potential CVID, possible signs to look out for include bronchiectasis, lymphadenopathy, hepatosplenomegaly, arthritis, and thyroid enlargement, and this is all due to the factors which we discussed on the previous slide. Investigations for someone with potential CVID firstly includes full blood count with differentials. Serum IgA, IgG, and IgM levels should be taken, and this is to assess for the severity of antibody deficiency, which can also be done by measuring antibodies to past immunizations and common pathogens, for example, Streptococcus pneumonia. CD3, CD4, CD8, and CD19 lymphocyte markers may also be measured, and this will help to quantify helper and cytotoxic T cells and B cells. Most patients with CVID will have normal circulating B cell levels. The differential diagnosis of CVID is vast and varying, and these can be divided into 3 broad categories. Firstly, there are secondary antibody deficiencies. These may be associated with drugs, for example, gold, penicillamine, antiepileptics, and cytotoxics, or associated with lymphoproliferative disorders, such as chronic leukemia, myeloma, and lymphoma. Post-bone marrow transplantation may also give rise to a secondary antibody deficiency and should be considered as a differential diagnosis. Secondly, Bruton's X-linked agammaglobulinemia is also a differential for this condition, but this would present at 4 months to 2 years and would also present with absent B cells and absent lymphoid tissue and no granulomas. Combined immunodeficiencies, which we will talk about in a later video, are associated with T-cell-associated infections and usually again present in childhood. The management of CVID and any primary immunodeficiency syndrome should really be multidisciplinary. These conditions are very complex and difficult to manage and do require input from several specialties. It's important to prevent and promptly treat infections with a prolonged course of antibiotics. Many of these patients will also be on prophylactic antibiotics. It's important to monitor for other autoimmune diseases that may develop in a person's life course, and administration of immunoglobulin, or IVIG, or subcutaneous immunoglobulin is the mainstay of treatment. Complications arising from CVID include bronchiectasis secondary to recurrent infections, anemia, thrombocytopenia, neutropenia, vitamin deficiencies resulting from malabsorption, and increased risk of malignancies, particularly lymphoma and gastric carcinoma. Let's now try a question. So, In evaluating a patient for Common Variable Immunodeficiency or CVID, which of the following findings is least likely to be consistent with this diagnosis? So our options are low serum levels of IgG and IgA, B, normal to increased numbers of B cells, C, good response to polysaccharide vaccines, D, recurrent bacterial infections, or E, chronic gastrointestinal symptoms. I'll just give you a second to have a think about that, given everything we've talked about in this video. So the answer which is consistent with the least likely finding in a person with CVID would be option C, a good response to polysaccharide vaccines. You will remember that this is actually one way that we test for presence of the condition by looking for a response to past immunizations, which may well be weak in these patients. All the other options may be seen in a person with CVID. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.